Hey everybody, Dr. Suneja here with Med School Tutors. We know this is the time of year when a lot of people are starting their rotations, so we wanted to help give you some tools so you can be successful on one of the most important rotations, internal medicine. So the first thing to do is be prepared. One of the things you can do to kick this off is talk to other students from multiple years. You can talk to them about various aspects of the rotation, things like the hours, if you're expected to stay after, what the expectations are for medical student presentations, and how many patients you cover at the beginning of the rotation compared to the end. You can also talk to students about how you're evaluated, but it is best to save this conversation for the clerkship director, who you definitely should ask early on what the rubric and criteria are for your evaluation. Remember that overall, everyone's experience is different, but you can still get valuable information by asking around. The next thing to do is to figure out your schedule so you can make time to study. If you carve out this time at the beginning, it will make it that much easier when the time comes to study. We'll talk more later about other nuts and bolts of studying and other ways to hold yourself accountable as well. Remember that your days off are going to be precious, so figure out when they are and plan the things you want to do on those days. Whatever it is that energizes you and makes you feel rested. That's going to a movie, exercising, or spending time with friends, whatever it is, just make sure you plan to do it in advance so you can be re-energized to get back to your rotation, take care of patients, and keep learning. Self-care is a really critical part of practicing medicine, and if you don't do it mindfully and deliberately, you won't be able to sustain a good mindset or good study habits on this rotation and throughout your clinical year, residency, and life in medicine. Remember as you start your rotation that your goals are to help provide patient care first and to learn. You'll meet residents you get along with, and some you may even become good or great friends with during your rotation. But that being said, remember that patient care is always the first priority. Some other things to consider are that there's a lot of information to keep track of on your internal medicine rotation. You might have exposure to this on different rotations, but internal medicine is a whole new ballgame. Some students will take a single sheet of paper, fold it hot dog-wise, divide it into sections, and put the results, updates, and checklists for the day there for each patient. Other folks will use printouts generated by the EMR as the starting point for how they take their notes during the day. See if you can find out what these printouts look like beforehand, or if you've been on other rotations, you may already know what works well for you and what doesn't. Next, remember the role of the resident versus the attending. This is a big one. Your attending sees you primarily on rounds. Sometimes attendings are around and about during the day and they can get a sense of how you do your daily work, but more often this is the role of the resident. Most medicine teams are structured the same way. There are interns who split the patients up, and there's usually one and sometimes two senior residents who supervise the interns. Medical students tend to carry patients alongside interns because they can't put in orders. Sometimes this can get frustrating because you'll have an update or something to consider about a patient, and your intern may give that update to your senior resident before you've had a chance to show people that, hey, I'm being proactive, I'm assessing patients, I'm following up on results, I'm thinking about changes in the treatment plan. The truth is, some residents and interns are better about this and will go out of their way to give you a chance to give those updates. But sometimes things are just too busy and patients are too sick to consider these kinds of things. The best thing you can do is be proactive when you want to communicate something to your team and to not take it personally if you feel like you did a lot of work that went unrecognized. If you stop putting in effort because you think no one is paying attention, trust me, it's not going to serve you well because they are paying attention. Another part of all of this that goes unrecognized is the power of emotional intelligence. Knowing when it's appropriate to give updates and when people need you to go run to the supply closet to get something is a big part of clinical year. In reality, it's a big part of medicine in any career. If someone's tachycardic, in atrial fibrillation with rapid ventricular rate, and hemodynamically unstable, it's not an appropriate time to give an update about a non-acute patient. In a situation like that, it's better to ask your senior, hey, can I do something to help? You want me to grab the nurse? Understanding how to prioritize patient care and having good self-awareness are just as valuable as having a good fund of knowledge. The basics are also really important on your rotation. You have to eat and sleep to function well. Remember, sleep has been proven to be a key aspect of consolidating memory and what you learn. Rotations are hard, and you might see some really sick people as well as work really hard and get some tough feedback about your performance. Make sure you have people you can call who know you're doing something difficult. Even if they're not in medical school, you can explain that this is going to be a tough time for you. If you do that, they'll be better equipped to give you the support you need. Remember on your rotation with your team that lying is the worst thing you can do. Once you do it, your trust with your resident and the supervising team is broken. I cannot stress this enough. If you don't know something or you didn't check on a lab, don't just say it was normal. Say, I don't know. Finally, having a good attitude, showing a desire to learn, and being professional are the basic principles of any rotation, and they're critically important on internal medicine as well. So next, we're going to move on to the clinical care piece, which is obviously a huge part of the rotation. So this is the structure of the vast majority of days on an internal medicine service. When you pre-round, make sure you've looked in the chart before for the vitals, new results, and overnight events. Another thing to think about, urine output. Then go see the patient. If you have time, touch base with the nurse to see if there were any other overnight events that the patient may not remember. On rounds, you're presenting your patient, most often in a SOAP format, unless it's an admission. And SOAP stands for subjective, objective, assessment, and plan. For patients who have been in the hospital for a long time, you can stick to the highlights, acute overnight events, any big updates from the late afternoon or evening the day before, and definitely overnight. Things like unstable vitals and medications that were required should also be included. Sometimes the attending knows about these events because they chart review or they talk to the senior resident on their own, but sometimes morning rounds are the only time an attending gets updated, and they let the senior resident take control during the day. Don't forget to also report in the subjective how your patient feels that morning, and include any relevant review of systems to the patient's complaint. Now, the objective part of your presentation should focus on your exam with specific attention to relevant aspects, as well as new labs and imaging. Your assessment and plan should be concise but thorough. This is where your attending is looking to see that you can put all the pieces together. If you've been reading about your patients, keeping track of changes in their clinical status, and being an active member of the team, you should be able to create a comprehensive plan. Sometimes your residents will help you with this. If there's time in the morning and you have questions about your presentation or certain aspects of the plan, see if your resident can help you. And always remember to include new parts of the plan in your presentation, but also to include things that have been getting done and should keep getting done. These are things like getting a certain medication every day for blood pressure or diabetes, or checking in with the renal team for the recommendations on a daily basis for a patient who has a renal transplant. Now, some attendings want this stuff to fall off after they've known the patient or after they've been in the hospital for a while, but let them tell you this. Or better yet, ask when you start your rotation and you can adjust as you move forward. You might also have presentations to give or questions your attending will ask you after a presentation. If you're assigned a topic presentation, do not blow it off. Ask about what the expectations are, and if no one tells you, at least ask for some advisement on the length of the presentation so you aren't giving a 5-minute presentation when people expect a 15-minute one. And remember, when an attending asks you questions, be honest about what you know and don't know. People can sense when you're making things up or rambling. Another thing I want to say about rounds is to pay attention. You can still get asked questions on patients you didn't present on, so it's a good reason to pay attention to everybody, not just the patients you presented. Now, after you present on rounds, you'll usually get together with your senior resident and do something called running the list. And that's where everyone talks about the different tasks for the day. Because you can't put in orders, the intern will do a lot of these tasks, but you should still take notes and be actively involved, because these are going to be things like medication changes that have to be in your plan the next day, as well as labs and images that you're going to want to follow up on. Another important part of this rotation is going to be consults to other services. And the theme you'll hear from everyone is this: the consultant always wants a specific question. They don't want a general review of the patient and then to be consulted because, hey, this patient's on dialysis, so we consulted the renal team. They always want something specific. Like, hey, can you get this patient started on dialysis because they missed a session yesterday and they're coming in with hyperkalemia? Now remember, during the day, you'll start to engage in the clinical work of carrying out the plan, reassessing the patient, following up on results, making these consults and following up on those recommendations, and doing admissions. When you're reassessing patients, think about when to do it during the day. If you're reassessing a patient after they've gotten diuresis for their heart failure, make sure they've actually gotten the medication and had time for it to work before you report an update. Remember, handoff is just letting the night team know what is going on, and each place will have a format. The most important thing to remember for the overnight handoff is what are the contingencies for a patient? What are the things to watch out for, and what are the things to do if those things happen? For the handoff and for rounds in general, and really just for all of your patients all the time, get familiar with your patient's one-liner. It's a summary that includes their age, how many days they've been in the hospital, their relevant past medical history, sometimes surgical history if they're recently post-op, and then a summary of their current condition. The next thing to consider is a lot of these aspects of clinical care that you'll be expected to do. You've probably seen a lot of this in your previous clerkships, but I'm going to highlight some aspects that I think is always important to remind yourself of. And I'll talk about these things from the perspective of an oral presentation, and then I'll talk about notes in the EMR and how these things are a little bit different later on. And so before I start, I want to remind you of something extremely important that you'll hear from residents and attendings all the time. Keep the subjective information in the history and the objective information in the objective. There is tons of information in internal medicine, and if you mix things up in a presentation, it's going to get confusing and people will remind you of it. You'll be ahead of the game if you already know that no matter what, you should be sticking to this organization. So for the history, as a medical student, you may have time to take longer histories than an intern might. Use that time, especially on admissions, to elicit information to fill in all the aspects of a patient's history, perhaps including more details about their previous hospitalizations and definitely the social history. One special thing I want to mention is the emergency department history for admissions. When you're presenting an admission, part of the history should be what is called the ED course. This is a summary of what their initial presentation was in the ED, what was done there, what critical labs were in the ED, and what their clinical status was by the time the patient made it to the medical floor. It's okay to include labs and other objective findings in the ED course, as long as they were things that happened in the ED. Once you start reporting your exam and your admission labs, that should be left in the objective. And for the subjective part of a SOAP presentation, remember to report how the patient's feeling that morning and any acute events that happened overnight, like unstable vitals, medications, and the things we talked about earlier. Now, in your admission presentation and the subjective part of your SOAP presentations, a really important part of these presentations is the review of systems. Now, this is something that takes a long time to master. When you report a patient's history, you'll have positive findings as well as negative findings, meaning you'll have positive signs and symptoms that they had and other ones that they didn't. Some of these things are relevant to your patient's ultimate diagnosis or to the things you're ruling out. Other things aren't. You want to say the things that are relevant as you go about your presentation in a way that shows you're attending, without saying it directly, that you were thinking about these things when you took the history. For example, when a patient with heart failure comes in and you're giving the history, you want to say, the patient reported shortness of breath when laying down, lower extremity swelling, so on and so forth. Then in your assessment, you can say, the patient had symptoms consistent with heart failure. Remember, you shouldn't say this in the history because it's an assessment. And remember, the history is for reporting subjective information. Now, the admission history and the subjective part of a SOAP presentation should always have that review of systems. A lot of medical students think that the review of systems is this list at the end of a history. But if you're doing it correctly, you can put the pertinent positives and negatives inside of the history as you're reporting it, and then at the end, you can have a short review of systems. If you can do this, it shows the team that you're thinking clinically rather than thinking in a formulaic way. And it's a difficult concept to wrap your head around. So ask your resident to walk you through it for your first admission and for some of your SOAP presentations, and make sure you read about the pathologies you're presenting on, because if you do, this whole concept of the review of systems and pertinent positives and pertinent negatives that I promise you're going to hear about will be much easier. Now, always remember that in an admission, you should do and also report a comprehensive physical exam. But as the patient stays in the hospital for a longer time, it often becomes clear that a few body systems are key for your SOAP presentations and notes. When you reassess patients in the morning, you should do a more comprehensive exam, but when you report the objective findings as part of the update on a patient, you can be a little bit more streamlined if you know that the attending or resident is interested in a key body system, and you can report the rest of the exam if asked. At the beginning of your clerkship, you might start by reporting everything, but as you move forward, try to get more focused and purposeful in what you report. Some attendings will even want the exam to be focused in the admission, but it's best for you to assume the team always wants more information and more comprehensive information when you're presenting an admission, and then you can get feedback and include less in future admissions. Now, for labs and other objective information, they should always be reported if the results are new. So in admission, report everything. For SOAP presentations, you should include the lab values and other objective results from the morning. Sometimes people do get confused about whether to report certain trends in certain lab values when presenting the objective portion. There's no right answer, but it's worth asking yourself, if I report this trend, is it going to change management for this patient? If someone's creatinine is 3 and the day before it was 2 and the day before that it was 1, that is a relevant trend to bring up. Now, your assessment and plan are extremely important. This is where you show your team that you can move past simply reporting information to actually synthesizing it. Medical students too often get bogged down by reporting information, but not giving enough time to analyzing it. You'll be ahead of the game if you're always thinking about the plan for a patient, and you make sure to get to it in both your admission and SOAP presentations. Remember, the assessment should be conversational but critical. It's based on the differential of a possible diagnosis, and then it's an argument for why some are more likely than others and what to do about it. Whether that means doing more tests to figure it out or starting treatment because you'll have evidence of what the disease is. Some students will spend time ruling out really rare, obscure diagnoses. This shows the team that you're thinking, but it doesn't make the most sense. And there's not a right answer here. So when you make your differential and you talk through it in your assessment, be broad and try to get a sense for exactly how broad your team wants you to be. And finally, for the plan, depending on your attending, the plan will either be problem-based or systems-based. Each of these styles has its pros and cons, and you might find that one of these better suits you. That being said, learn which style is expected on rounds and in your notes, and learn each day based on the feedback you get, how the team talks about your assessment and plan, how you can update it for the next day. Some specific things to also include in your plan that people forget sometimes: discharge planning, and then items like consults. Now, I'm going to loop back around to keeping track of things that are going on during the day. It can be intimidating and difficult because there's a lot. But have a plan when you start, and as we talked about earlier, be open to that method of data tracking changing. But I'll tell you, regardless of how you keep track of information and updates, the one thing you should 100% do, no matter what, is make checklists for the tasks that you need to complete during the day or the things you want to help with. I might even recommend occasionally adding things to look up or read about, which will help you loop back around and do some reading or studying if you need to. And remember that some of the things you might get asked to do by your team might not seem like real medicine. But the truth is, it takes a whole team to take care of a patient. And many times, tasks that you complete are the ones that nobody else has the time or ability to. And all of these things really do contribute to patient care. Now, some other notes about doing an admission. Usually admissions are pretty straightforward. Sometimes you may be directed to go see the patient and report back to the team, but other times you'll go with the senior or the intern to take the history. Now be flexible and ask your team what they would prefer. If you go with the intern, ask questions together. When it comes to the assessment and plan, if the admission is during the day, you should try to make a plan for yourself and use a pocket reference that you have with you, or up to date or other internet resources. This way, you can run through your rough plan with the team or your resident and make updates when you go home so that your admission presentation in the morning is more refined than the initial note you wrote during the day. And when you go home and you write a longer or more thorough admission presentation, just remember that you might not have time to read the full presentation. So think about the aspects of the history that you might trim down or parts of the differential that you can maybe narrow in case morning rounds are really busy because there were a lot of overnight admissions or something like that. We should talk about notes because they're a part of medicine, and even if they're irritating, they really do have the capacity to dramatically improve patient care. If you do an admission, writing the note can be quite easy. You write down everything you learned in an organized fashion in the categories that we all learn about. History of present illness, past medical history, past surgical history, meds, allergies, social history, physical exam, labs and other objective findings, and then of course, assessment and plan. SOAP notes, on the other hand, provide updates on patients and are often much shorter, including all the things we've talked about earlier in the presentation, but the plan is often a running list of things that have happened, with only a few aspects that are new. Now, in your notes, make sure you actually change the assessment and plan each day, even if only a few things have actually changed. I've seen people get burned on this. If you pay attention to these notes, it will help your learning and your team will be extremely appreciative, which always helps with your evaluations if your intern or your senior doesn't always feel like they have to edit or rewrite your notes. So again, for notes, the trick is really learning how to translate all of this into a verbal presentation, and we spend a lot of time talking about how to do that. And in terms of your presentations, remember that practicing them can be very helpful. If you can do this with a resident, that's probably best, maybe at the end of the day if you've been working on it and it's an admission presentation, or in the morning if it's a SOAP presentation and you have time. Otherwise, practicing in front of a mirror out loud to yourself can actually really help you notice if you're saying a lot or rambling. So the last part that we should talk about is studying, because you'll have a shelf, and studying is also one of the main ways that you'll gather information when you're not in the hospital. So first, anchoring your learning to patients is going to help you retain information, and I promise you that is a fact. If you set a goal to learn something from every patient, it's going to serve you very well. You should be reviewing the pathophysiology, presentation, and treatment for all the things you see in your patients. And if you can, also for all the things on the differential for those patients. Now, Step Up to Medicine is a great resource for reviewing individual patient pathologies. It's more comprehensive than just putting a disease into Google, and it will serve you well come Step 2 CK when you want to be at least somewhat familiar with this text. Now, Up to Date is great, especially for looking stuff up during the day at the hospital and making sure your assessment and plan are consistent with current literature, because Up to Date is basically a search engine for clinical information. But it should not be used as the only way that you're studying, and that's really important. Of course, sometimes you also won't have a lot of time for some of these resources, so quick references like case files or med bullets can also be extremely helpful. And even sometimes you won't have energy, and we recognize this. In these cases, it's still important to try to review information and learn something, and you can do that by perhaps watching videos on online med ed, or doing a smaller number of questions on UWorld, or just reading 1 or 2 pages on Up to Date. Making a schedule for the rotation to do all these things can be tough. Sometimes you'll get off early, and other times you'll get off much later, which can make sticking to a schedule challenging. So one thing you can do to help you with this is set a minimum achievable goal for every day. Perhaps tell yourself that you'll study for at least 1.5 hours each day, and you'll include time that you spent studying during the day. Then if you have more time, you can do more. But you know that for your rotation, this is what you need to get done on average every day of the week. Another way to hold yourself accountable is by studying with a friend or friends, or having an accountability buddy who will check in with you or who you will check in with. Now, when you do questions, remember to read the full answer explanation for questions you get right and questions you get wrong. Ultimately, this is what's going to help you get more in-depth knowledge, and it will serve you better for patient care, for Step 2 CK, and for your shelf. It's always better to do 10 questions and take the time to read the explanation than it is to do 20 or 30 questions and just skim the answers. Remember, you're practicing test-taking strategies when you do the question, but to learn the content, you have to actually take the time to read the explanations. Now, practice NBMEs are another really important source of questions that will help you practice for your shelf. I think it's best to wait to use these until at least the midpoint of the rotation, when you've had some time to study and get familiar with some of the most common pathologies. Remember that everybody learns differently. Important things to consider are that active learning, like reading, questions, note cards, making your own notes, is going to help you retain better than passive learning, like videos. You can use both of these, but make sure you don't rely entirely on passive learning, like only watching online med-ed videos. Things you should aspire to as priorities are getting through as much of the QBank as you can and trying to refer to Step Up to Medicine when you're reading about your patients, making your own assessments and plans, and going through the QBank. If you have time, it can be helpful to take notes in Step Up to Medicine using UWorld. Other question banks like Kaplan and Ambus are nice, but UWorld is going to have the highest yield information. Now remember, note cards like Anki and Memorank are great for spaced repetition, but it can be hard to make these decks yourself. If you have time, it's a great idea, but you can also often find decks online, and it's a great way to review focused topics that you may be weaker in. Other question banks are emerging, like I talked about, and they can be helpful for more obscure material. But again, remember, for your clerkship and for the limited time that you'll probably have to study, that sticking to UWorld is probably best. Things like Pocket Medicine and case files, as I've talked about, are great resources to have on the go, especially in the hospital as quick references for admissions, rounds, or throughout the day when there's too many med students or too many residents around, and logging onto a computer and looking something up is going to be too difficult or is not feasible for some reason. You can also use case files for content review if you don't have time for a Step Up to Medicine section. While Pocket Medicine is intended more as a real-time reference for sort of brief, up-to-date clinical information, almost like a shorter version of up-to-date. So we've talked about a lot. The medicine clerkship really is a challenge, but it's also a chance to really explore and enjoy the reason that you became a physician. I hope this was helpful. And remember, you're not in this alone. If you find that you're struggling on your rotations, or you want that extra edge on your studies for your shelf or Step 2 CK, we're here to help you work as efficiently and effectively as possible. Don't hesitate to reach out to us at 212-327-0098 or hq@medschooltutors.com. Thanks for your time, and good luck on your rotation.